Sir, we are live now. With all your permission, I'm starting this session.
Go ahead.
A very good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. K. Suresh, sir. Let me share some of the achievement of the sir. Sir has done MD, DIH, DF, FIAP, FIPHA, FISCD, Family Physician and Public Health Consultant, Bangalore, and visiting professor of practice at KSRDRU, Gadan, Karnataka. And today he is going to speak on a topic management of constipation in a smaller setting. By taking not much time, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you, Vyas. Welcome, doctor friends. Today's issue is a common one, usually not given due importance, and it is equally challenging. We all know in our routine practice, people come with different complaints. Probably one of the common thing after fever or diarrhea is constipation. I'm saying challenging because the definition itself is not universal. So today what I'm trying to do is try to describe how this is explained by the clients who come to us. What do the international people consider as constipation and what is good for Indian people to consider constipation. As I told you, inferring the reason for constipation is not as easy. So is the treatment. In the treatment, the role of medicines is minimal, but the ability to interact with our client, find out what is the individual reason for the complaint, and then try to sort out, which I call the approach as DEAD, DED, dead. Diet, exercise, and drugs come last. So with this introduction, we'll walk through some of these slides. The first slide, as you can see, basically the introduction says an international definition, which says that if the bowel movements are less than 3 per week, imagine in an Indian, this looks like a laughing stock. For Indians, if you do not pass your bowels at least once a day, and most Indians do it twice a day. So we consider that as a consideration. But here, even if you take 3 bowel movements a week, 25% of the time people have the constipation. Basically, patients who come to us complain of is commonest is I need to strain, doctor. Without straining, I can't pass the stools. Or they concerned about the consistency of the stools, how it looks like. Thanks to the Western commode, in the urban areas, most people can't even see their stool. Therefore, they don't even attach what it looks like. Most patients with chronic constipation largely come to a primary care physician. I'm using this word very carefully. Either you are in a general practice or what we call as a private practice or working at a health center or a health unit, sometimes even an Indian system doctor. So most cases approach us, and probably of late we are having this phobia or fascination for gastroenterologists. The moment anything has to enter our gastrointestinal system, urban elite think of a gastroenterologist, and they are very comfortable doing two things: putting a tube from top endoscopy, or putting a tube from bottom, which we call colonoscopy. So, for Indian people, I would use a definition: a stool frequency of less than 5 times in a week, or a subjective feeling of incomplete evacuation. The person always says, "Sir, I don't think I have completely finished. There is still something stuck there." Appears to be a good practical definition of constipation for practicing doctors. We also know how it adversely impacts our quality of life. A person who doesn't pass the stool every day feels he is missing something on that day and starts thinking of more of his constipation than any other activities in his life, as if that is the only thing which decides his life. Most of these cases can be, and we are all managing them in our own way. But situations have changed. You may have to need to rest, refer them to a specialist. Now, with all given indications, we do not know what is the incidence or prevalence of constipation. The data is lacking, but we are definitely much better than the Western world because of the vegetarianism, which gives high fiber intake. Therefore, instead of 3 per week, we consider 5 per week frequency as an acceptable bowel movement. So basically, the existing data is underreported because half of our population solves the problem at home using laxatives, which are easily available on the counter. Now, what are the common complaints which we see in our practice? Most of you might be knowing, as we have already told, infrequent bowel movements. That means in a week of 7 days, if person does not pass at least 5 times, he or she has a feeling that they have not done justice to the bowel movement. Second group of people complain of need to strain. When the issue of straining comes, it's combination of two things: what they eat, whether there is enough fiber or not. Second is, when I look at a little later, is how they sit. Our westernizing culture, from squatting, Indian squatting plate to the commode, has added to this problem. The third complaint people talk of is hard or lumpy stools, followed by feeling of incomplete evacuation. Or some people may also say, as if something is blocking, my stool is not coming out. In children, we are seen complaining of not able to pass unless the parents use digital or evacuation. I remember my own child way back about 35 years ago, where I had to use initially for first days digital or fingers to move the stool, because those children do not eat enough of fiber. Sometimes there may be complaints of abdominal pain or discomfort, bloating, gas. The issue of gas and bloating is common among diabetics among the adults because of the various drugs we use. They themselves create the gas and bloating. Now, looking at some how the practicing doctors come across. We know we have 4 categories of doctors in India, what we generally call as general practitioners or primary care practitioners, which includes all systems of medicine. We see that self-reported constipation is about 25% of the people who come to us. They themselves say, you don't have to diagnose anything. But if you look at signs and symptoms, 16% of the patients have some symptoms of constipation. But if your patients, if you are catering to the elderly people, the incidence doubles to around 32 to 33%. General physician, these are physicians with MD qualification, may see about 5% of their cases as constipation. Surgeons have started, you see, they are what we call as a secondary constipation, usually 10 to 15% of their cases. If you go to gastroenterologist, surgeons may be much higher. The commonest cause in India for constipation belonging to surgical categories are fissure in ano, fistula in ano, piles, then colorectal pathologies including cancers. So as you know, anus is a short tube connecting our rectum to anus, anal opening. The anal fissures make having the bowel movement very painful. Therefore, the person has to struggle, and the more he struggles, the more is the pain, and it's a vicious cycle. If fissure is not helped by softening of the stool using laxatives, the constipation will continue for long. Fistulotomy also sometimes lead to constipation because these sphincters might have got damaged. In gastroenterology, which is more a phenomenon of district headquarters and above, they are seeing most cases of colorectal surgery where colonoscopy gives them an indication. Surgery may be required to look at the masses or remove the masses, or sometimes the nerves of the colon or rectum. We'll come to that a little later. The surgical intervention comes into the picture only when all dead issues which I told you, diet, exercise, and drugs do not work. Now, if a case comes, what do? We look more at the practical thing, not the theoretically, we come later theoretical discussions. The first step for each one of the practitioners is to decide whether the constipation is primary or secondary. Primary constipations were also called as functional constipation, which include even the irritable bowel syndrome with constipation. You know, IBS has two components, either with constipation or with diarrhea. In the functional constipation, one need to distinguish between IBS constipation because the management differs. IBS constipation is significant, is differentiated by the presence of abdominal pain or discomfort, whereas the functional constipation do not usually have abdominal pain or discomfort. It's just a constipation unless there are now 3 to 4 days have not passed, they may not have any abdominal pain. Their main complaint will be passing of hard stool or infrequent stool or need for straining or feeling of incomplete emptying. Then, as I told you, in the children, we may have what is called as obstructed defecation, which may need digital facilitation for stool removal. We also know the constipation is secondary to so many conditions like metabolic, endocrinal, neurological, psychological causes, or use of some medicines themselves. Surgical causes, we have always listed piles, fissures, fistulas, rectocele, enteroceles, which is not the issue of discussion for the day. Now, the physicians managing chronic constipation should be alert by certain alarming symptoms because some of these conditions may need immediate referral. So, which are those red flags? First is if you come across a person who is aged more than 40 with an unexplained weight loss and abdominal pain, first risk. So, do not try to meddle if you come across these two key signs. Any person aged less than 50 with rectal bleeding or abdominal pain or weight loss is another second category of people who are at higher risk, which probably need to be referred directly, not meddled with. People aged more than 50 with unexplained rectal bleeding, abdominal pain, or weight loss, and people aged more than 60 with anemia. See, sometimes the bleeding uh, is not even observed by the clients. And as I told you, the Western commode had made us to not even look at that because the moment it falls, it goes and you flush it out. There is another thing which is called as obstipation, which is a condition where person cannot pass stool or even gas, a signal of severe problem. So if there is somebody who says, I don't even pass eggs, doctor, better you do not try to meddle there. Obstipation may also lead to abdominal discomfort, cramps. Again, we have listed the rectal and anal conditions as we discussed. Technically speaking, we talk of three types or three reason-based constipation. First one, which is the commonest, is known as normal transit constipation. Here, the problem is with the muscles or the nerves that control the bowel movement. You can see the muscular portion in the rectal areas. If some people either muscle themselves or the nerves supplying them are not doing their job right. This is more common among young children and elderly people. It either could be a medical condition or general body waste disposal functioning is poor. So everybody's waste moves at a particular speed. There is no need to compete each other. Each one of us have our own. Still, our stool may be hard and difficult to pass. Abdominal pain or bloating is common among these people, and it usually gets better just by eating more foods which contain fiber. We'll come to that what those fibers are using certain kind of laxatives where the bulk increases and it allows the easy movement. The second category is what is called as a slow transit constipation. This is characterized by reduced motility of the large intestine. Usually the enteric nerves leading abnormalities in the nervous system there. So what happens here is they don't even feel the urge to go to the bathroom. They may poop less than once a week, passing dry and hard stool, a bloated belly. These are common among women, particularly who are tense. The moment they get tense, they can't pass their stools. Here, the laxatives and fibers do not help much. There is what is called as a behavioral training, biofeedback has to be tried. If doesn't help, surgery is the only option. The other third category is what is called as pelvic floor dysfunction constipation. Here, our pelvic floor muscles in the rectum and around are tight, are unable to relax, Therefore, it becomes difficult to pass to. 50% of the chronic constipation people have this, what we call as a pelvic floor dysfunction, for short PFD. That is where a general practitioner needs to be little more taking detailed history, observing certain things. I'll come to that later. So impaired relaxation and coordination of the pelvic floor muscles and abdominal muscles during the evacuation process is the problem. Therefore, they have to strain hard or sometimes even thin stools. A feeling of incomplete elimination are the key signs in this condition. This unknown caller. Now let us look what has the recent research has brought to us. This is one important thing I want every doctor to be aware. Use of anti-diabetic drugs, particularly GLP-1, which are common now being used among people who have diabetes along with cardiac problem, atherosclerosis, cardiovascular diseases. The latest research says that these drugs can create constipation. So make it a practice to ask every patient who talks of constipation, if he is diabetic, if yes, what drugs are taking, if see if any one of GLP-1 drugs are prescribed. I have listed some of them. Short acting is Byetta, Adlexine, and Rivalosis. And some of them are oral, some of them are even injections for long-term effect. Now, if you look at what is the incidence of prevalence, globally, if you look at it, this is based on a study of about 3 lakh people, that is 2,75,260 subjects in 80 different populations. The pooled prevalence of constipation is around 15%. Using what is called as Rome 1 criteria, 11% if you use Roman category 2 or Roman category 3. We'll come to this categorization a little later. And 10% if we use the Roman category 4. Prevalence of functional constipation is 2 times higher in women irrespective of definition used. So basically because it's a psychological effect. Women get mentally disturbed a lot. Men try to push it off, manage to neglect, but women are more psychological, as we all know. There is a significant heterogeneity between the studies done in the different countries. Therefore, one single standard cannot be used. If we use a uniform symptom-based criteria as used, prevalence varies between different countries. So environmental, cultural, ethics, dietary practices, and genetic factors play in influencing the constipation symptoms. And this is the magnitude of the functional constipation of problem. As you can see, I told you, if you use different category, it ranges between 10 to 15%. And more important here is one looks at which are the countries which have the highest prevalence. South Korea reports around 24%, Turkey same around 24%, Netherlands same, and Ghana 26%, India 16%. Among the lowest countries, Australia has the least, which is about 8%, China about 5%, Germany 0.2%, and Honduras 1%. These are the global standards. What influences? This study brought out saying that old age, where odd ratio is 1.55. Odd ratio means if an average person passes 1, here the risk is about 1.5 times. Poor physical activities, OR is 0.56. That means person who do not do activities, their constipation goes much higher. Opium consumption, anxiety, which is common among women, as we told you, has an OR of 1.38. Depression, again, similar thing. Back pain or joint pains. Both of them minimize their ability to use their muscles. Insomnia, that is sleeplessness, has the highest 1.62 odd ratio, and gastroesophageal reflux has again OR of 1.5. Now, these are the pictures one need to look at. This is the commonest used, what is called as a British or Bristol stool scale. Here, type 1, which is a separated hard lump. Your stool is, if it is separated hard lump, that means you need to ask your patient is his stool. As I told you again, in urban area, it might be difficult because of the use of Western commodes. So separated hard lumps is indication of severe constipation. Lumpy and sausage-like stool indicates mild constipation, and any a sausage shape with plain surface is normal. Smooth, soft sausage like snake-like stool passing is again normal. If you get soft blobs with clear-cut edges, it indicates lacking fiber. Musky consistency with ragged edges is mild diarrhea. Liquid consistency, we all know, is a indicative of severe diarrhea. So basically, clinically, you need to look at type 1 and type 2 as the constipation problems. Now, this is the Roman categories where we use category 3 and category 4. These are the latest. In category 3, it is basically applicable to IBS, where abdominal pain or discomfort is there. What happens here is improvement is there with once the defecation is done, they are more comfortable. The onset is associated with a change in frequency of stools and change in the form of stool appearance. Discomfort means an uncomfortable sensation not described as pain. They just say it's not pain, sir, but some discomfort. In Roman category 2, it is mostly related to defecation, associated with change in the frequency of stools, change in the form, or that is the appearance of the stools. This criteria is fulfilled for the last 3 months with symptoms that is onset or at least 6 months prior to diagnosis. The criteria we use here is a diagnosis of functional constipation has to be made if at least 2 of the following criteria in the last 3 months are met, or the symptom onset is at least 6 months old. Straining on more than 25% of the time. That means if they are passing stool, let us say 10 times in a week, at least 2-3 times they are facing this problem. Lumpy or hard stool, again, at least 25% of the times, and sensation of incompleteness. If we use the Roman 2 categories, here there is a big relief after defecation. Now here the patient must have at least 12 weeks of abdominal discomfort, which has to be continuous or consecutive in the preceding 12 months with at least 2 of the following 3 features. Relieved with after defecation, onset with change of stool consistency, and onsets associated with change in the stool form or these are the diagnostic criteria. Now, one of the things which we do not practice, which I would urge all of you to keep in mind, the checking how your client is squatting for passing vowel movements. We public health experts agree that the Indian type of squatting is the best position for people to poop. But unfortunately, modernization and aping the Western world, we have moved to use of commodes. So here, what does squatting do? Squatting helps people to complete a vowel movement, particularly if they are constipated. This position allows the abdominal muscles to work efficiently, helping the individual to empty their bowels. You can see the right picture how it helps. Western toilet design encourages people to sit upright while pooping. See, you can this lady are sitting here, which is not conducive for passing stools. Sitting is less effective way of pooping as it adds unnecessary kinks in the person's rectum, making it harder for them to. So here, this is one of the ticklish issues most of the doctors are hesitant to ask. What they do is usually prescribe some laxative. So therefore, one important change in our behavior is to assess how these people sit. And sometimes, if the commode does not allow, they can use what is called as a pedestal toilet, which automatically gets a footrest, or alternatively, one can use a stool to sit so that the body is sitting at an acute angle. Then it helps movement. The bottom line to make sure and ensure is the person's knees must be at a higher level than his buttocks, his or her buttocks, while they are sitting for squatting for defecation. So therefore, our job is to assess toilet habit and advise if something is wrong about the healthy habit. What are those healthy habits? Allowing enough time to poop without straining. Most of us, the moment they sit, they start straining. As if they are in a hurry, they have to catch a train. So therefore, enough time must be before one starts training, give enough time. Trying to poop at regular times each day. There is nothing like the morning itself is good. As long as the person practices to use the loo at the same time every day, that is enough. Using a stool rise, I told you, to make the knees above the hip level when they are using a commode may help some of those constipated patients. Using the toilet after feeling the urge to poop. So don't go and sit just because it is time. You must also feel there is an urge to poop. While in the process of cleaning, one need to clean from back to front, basically to minimize the infections, particularly among the women, from anus to vagina, etc. Washing hands after pooping, using, again, this was an international consultation, big, whether using a tissue paper is good practice or ablution. Finally, it is agreed that it is ablution which is the best. Where there is a difficult to do this, then paper may be an alternative. Now, Indian hospital-based studies have indicated that the predominant stool type is 1 to 3 according to Indian standard in about 94% of the people. Nearly 68% of the people pass stool of type 192. 51% reported a frequency of 3 to 4 motions per week. 20% had no normal stool frequency by Indian standard, which is at least one bowel movement per day, and nearly 35%, that is one third of them, have less than 3 motions per week. Feeling incomplete evacuation is universal, which people describe as constipation. Nearly 69% of the people have functional constipation. mostly elderly people with some comorbidities. Only 2% have the colorectal cancer problem in the constipation in India. These are the key symptoms which I already said. Straining during at least 1/4 of the number of time defecation they go is the most common symptom. Lumpy or hard stool follows next. Sensation is incomplete is almost maximum of them complete. And sensation of anorectal obstruction. Some people I feel that something is obstructed, which is around 8%. Manual maneuvers required, maybe around 10%, say 8%, usually in children or very elderly who is sick and frail. If you use the Western standard of 3 defecations per week, in India, we have about 35% or 36% of the people who fit into that categories. In another study called a SMART study in 2021, the mean age of the patient was about 54 years. That means this is a problem of mostly, and majority of them, 2/3 of them were males. Most reported influencing lifestyle parameters, including not very active, lightly active, or non-vegetarian diet. In India, squatting continues to be the common mode of defecation, Indian squatting, because of the rural population. So basically this study says that chronic constipation is more common among males. It is influenced by lifestyle parameters associated with comorbidities like diabetes, hypothyroidism, antihypertensive drugs, and iron supplements and opiates are commonly noted to cause constipation. So please check if they are taking any of these drugs and try to see how it can be modified. Lactulose solution is the most commonly prescribed pharmacotherapy for most of these constipation people in India. There's only one community-based study in India, which was that too a decade ago almost, which brought that even if you survey everybody in the community, 25% of them report what is called a self-reporting of constipation. If you use round 2 category, only 1/3 or 2/3 of them, that is around 17%, will fall into category. And most of the subjects are in the age group of 18 to 59 years. Mean age was around 39 years. Constipation was significantly more frequent here in females than males, and non-working population than working population. Reasons were poor dietary habit, lesser fluid intake per day, and lesser physical activity. Consultation, as far as consultation is concerned, 8% reported the use of laxatives in the community survey on their own. What do our Indian gastroenterologists, as back as 2018, they have studied the situation across the country, practitioners among themselves. They looked at about 2,700 patients. According to them, the median stool frequency, as I told you, twice per day, 14 per week is common for Indian people. Half of them reported experiencing constipation. Nearly 1/3 of them had a stool frequency of less than 3 per week. In another multi-centric study, among the 1,600 patients, chronic lower gastrointestinal symptoms were present in about 29%, and they had perceived constipation to the tune of about 1/3, 29%. Applying the stool frequency criteria, only less than 20% were diagnosed as chronic constipation. Now, as a practitioner, if you can follow this flow chart, it will be useful to come to an early conclusion. Decide whether you need to refer or you can take the case with you. First thing is exclude if there are any drugs or organic causes are there. Look whether he is taking antidiabetics, antihypertensive, anxiety relievers, etc., etc. Or organic causes means there is a lump there, there is a fistula, there is a fissure, or anything. Exclude that. Then do a detailed history and physical examination. Look for if there are any alarming. We told you the red signals. We'll come back to them again. And stool for occult blood. Occult blood is a common thing you get investigated to see if there is a blood. If none of these are there, this means you can start the treatment. If any one of these is there, please refer the case to a gastroenterologist for colonoscopy and other relevant tests. So if you have to manage, what is that you can do? Initiate the treatment first. Here I told you lifestyle modification includes diet, asking to take more fluid, doing exercises, we'll come to them each one of them later, and optimizing the position they are sitting, use of laxatives. So if there is no bloating or not on high fiber diet, ask the bulk laxative that is there, osmotic laxatives are there, you can prescribe them, or stool softeners. If there is a bloating and if the person is already on high fiber diet, use osmotic laxatives or stool softener for treating the look at and treat the bloating, whatever they are bloating for. If there is a good response, continue treatment, he or she should be fine. If the response is not good, refer it. Based on these algorithm, the polyethylene glycol, or known as PEG, milk of magnesia are the best laxatives used in the Indian situation. If you have to do a distal examination, there are a few steps one need to be careful doing. Do not hesitate to do it. Don't think it is only a colorectal surgeon's job. As a general practitioner, we should be able to distinguish certain things. So here, first you need to explain the procedure to the patient first. What he does, for example, recently we were with a endoscopist, colonologist for a case. He tells the patient what is he going to do. I am going to put finger, I am going to put a scope inside. First thing is tell them what you have. Otherwise, they suddenly get the sphincter becomes tight and you can't do much. Second is first thing you need to do is inspection of the anus and its surrounding area under good light source. Don't We have seen people doing distal examination, putting the finger inside the anus and they are looking somewhere outside because it is smelly. That doesn't help. One need to look at the bright light. So go here, the patient must be in the left lateral position with the hips flexed at 90 degrees and inspect the perineum for any skin excoriations, scars or tags, condyloma, hemorrhoids, fissures, fistulas, and rectal prolapse, particularly among women. So that is what you do at an inspection level. Don't touch straight away. Then you look at the evaluation of perianal sensation. What is for anocutaneous reflexes? What does it mean? If you stroke the skin around the anus centripetally in all four quadrants by using a cotton bud and look for brisk contraction of the perianal skin, the anoderm or the external canal sphincter, you will see whether it is functional or not. Fourth is you do digital palpation upon gently advancing the lubricated gloved index finger into the rectum. Feel the mucosa, surrounding muscles, bone, other adjoining structures, and evaluate presence of any tenderness, spasm, mass, rectocele, stricture, etc. Hard stools, sometimes it is stuck there. Third thing you will use to maneuver to assess the anorectal function. What you do? Assess the resting anal sphincter tone, anal canal length, anorectal angle, any palpable anal sphincter defect. Then ask the patient to squeeze to evaluate the squeeze anal sphincter pressure, whether he can do it or not. Finally, after the finger in the rectum, place the other hand over the abdomen and ask the patient to push or bear down as if to defecate and evaluate whether the push of effort of abdominal muscle is there or not, relaxation or contraction of the anal sphincter is there or not, and tuborectalis muscle. Third, degree of perineal descent if there is any, and rectal mucosal intussusception if there are any. Finally, look at your finger if you can see any blood. So this becomes a very important thing. Very often general practitioners are reluctant to do this, so you may miss quite a few and referral may delay. Now here, what is called as a refractory chronic constipation, which needs a tertiary care facility. So you need to be able to diagnose and refer immediately instead of wasting time. What you do is clinical suspicion of the fecal evacuation disorder. Physiological testing is done by CTT and VET arm defectography. If there is yes, then all is normal. CTT is abnormal. So these things you are not going to do much after this test, which a gastroenterologist is to do. We will not get into these details. So what you can do is just try the laxative for 4 to 8 weeks. If that helps, well and good. Otherwise, continue the treatment. If not, refer to a gastroenterologist. Next thing after testing his sitting position, we have to do is look at muscles which you have done into a digital examination and train them. The common exercises are known as Kegel's exercise. For men and women, they are little different. What you are doing to do is ask the person to squeeze his pelvic floor muscles for about 5 seconds. Keep from holding the breath. Try counting out loud and then relax for another. So 5 minutes of holding, counting, 5 minutes of relaxation. They must do this 10 times per session and at least 3 to 4 sessions per day. That I am telling you gives good results. Starting from about 10 seconds, this can increase on holding from 5 seconds to 10 seconds, 10 to 15 seconds. The more they do, this will improve their ability to defecate. Some of the pelvic floor strengthening exercises are shown here. You can see, which we call as Pavanamuktasana. Can be educated. Yoga has a lot of this. And look at those exercises which are self-explanatory. Now this is how you help them to do. First is one leg putting to the chest, putting as much pressure as possible. And then this second, both legs. Most important is twisting position. Here you see the lady is lying straight but putting her thigh across and then trying to twist the body, which helps the intestines to move the stool downwards. So one need to demonstrate these Kegel's exercise. It is not easy to do. Therefore, I think we as doctors must be able to do these basic exercise so that you can demonstrate, ask them to do under your nose, which we call as supervised performance. Get satisfied that they can do it, and then ask them to practice at home. Then we come to what are the medical treatment. Basically, there are classified into two categories treatment: home remedies, most of which the person would have tried before coming to you. So be careful. But however, you can check and see if there is anything need to be improved. There are five things. One is dehydration causes constipation. Most people, particularly elderly, don't drink enough water. So see if they are drinking at least 2 liters of water a day. Do not wait for being thirsty. And as a therapeutic, sparkling water is better than the normal water. Eating more fiber, which increases the bulk and helps in bowel movements. There are three categories of fibers. One is insoluble fibers, which are bran, vegetables, whole grains. They add bulk and helps moving the bowels easily. Soluble fibers like oat bran, barley, nuts, seeds, beans, lentils, and peas, and some fruits absorb water from the gut and therefore increase the quality, and then the stool becomes gel-like paste which softens and helps the moving out. Non-fermentable soluble fibers such as psyllium are the best choice for treating constipation if you are to give some treatment. To prevent constipation, advise your patient to consume a mix of soluble and insoluble fibers. The proportion required is about 25 grams per day for females and almost 40 grams for males. So they should get a mix of these for a long-term result. Exercising more, we have already told what exercises can be advised, especially pelvic floor muscle exercises. Drinking caffeinated coffee also helps sometimes for people who are not used to it. If they are already consuming half a dozen cup of coffee, do not again some more. That doesn't help. Finally, taking senna or herbal laxatives, most people would have come. In the rural population, they take castor oil, which is very dangerous. Sometimes it may create problem. Best thing is senna, which contains plant glycosides, stimulates the nerves in the gut and improves the bowel movement. In terms of going beyond the home remedies, which you need to do is asking for over the counter or prescription laxatives. You know there are three categories. One are bulking agents. You have a lot of these in the market, which is called as Softolax, Isomagul, etc. Stool softeners like Isolax sachets, Laxopeg. There are many of them which soften the stool and therefore facilitate. And there are stimulant laxatives which are Stulidesigar, Laxopag, etc., etc. And there are all osmotic laxatives. So you can use any of them. Commonly, practitioners use milk of magnesia or liquid paraffin, or which is also known as cremophene. What you need to do as medical intervention is advise eating probiotic foods or taking probiotic or prebiotic foods. Probiotics are contain bacteria of bifidobacteria and lactobacillus. If they take this probiotic 2 to 4 weeks, which definitely helps their constipation. Alternatively, prebiotics in terms of yogurt, garlic, onion, bananas every day, chickpeas, and some other Western items which I don't want to go through because they are not available in India. Other thing you need to do is advise them what we call as a FODMAP, which is fermentable oligosaccharides, disaccharides, monosaccharides on polyols, diet to relieve IBC related constipation. Magnesium citrate, an over-the-counter supplement which is used before you do a coloroscopy or fistulectomy so that the bowels are allocated, can be used even at home. Advising to eat prunes. Prunes are nothing but dried plums, which are naturally dried, are called as aloo bukharas. They contain what are called as sugar alcohol sorbitol, which has a laxative effect. Advise avoiding dairy products. Some of them are lactose intolerance, may cause constipation. Therefore, if they are Ask them to avoid. When should you refer a case? This is a moot question. Should you handle or not? We have already gone through. Just to summarize, the frequency of bowel movements ultimately varies from person to person. Therefore, it is for you to decide. But if there is less than 3 times a week, definitely you need to be considered as a constipation. You might consider the patient as constipated if he or her bowel movements are very small, very hard, or difficult to pass. Better refer any case that is constipated for more weeks than not. You ask them in the last 3 months how many times you had this problem. If the number is more than 6 out of the 12 weeks, better refer them. Constipation can have many causes. Let the clear diagnosis be done by a gastroenterologist. Now, one latest information for you. I know you will not be able to do this at your level. What is called as a laser therapy for constipation is becoming popular across the world. Here, low-level laser therapy is also called as biomodulation or neuromodulation is used and has proved to be good for chronic constipation. One of the randomized control study recently done has indicated that this is better than giving the commonly used osmotic laxatives. A single session of sacral low-level laser therapy increases the autonomic nervous activity and therefore facilitate a Canada study reports. Sometimes tumors, benign or otherwise, can be removed using laser therapy, and even if they are cancerous, photodynamic therapy helps to reduce the size and therefore minimize the defecation. Dear friends, just to summarize, chronic constipation tests your life skill facilitation than medicines. I'm sure all of you will strive to keep to this test. Thank you. Fierce, I hand over to you.
Thank you so much, sir, for giving out your valuable time and sharing your knowledge with us and making this session informative one. Sir, I can see one question from Dr. Nitin Narula. He's asking, kindly tell me something about serve constipation in elderly people age 80. How to manage it?
What constipation?
Serve constipation in elderly people age
Yeah,
80.
okay. See, I since you use the age, let me tell you, I am also age 80. Here, the most reason for constipation are three. One, their muscles in Indian community, most men or even women do not use their muscles. And the basic principle of myology or muscular strength is use it or lose it. So what we need to see is train them for using their pelvic floor muscles. That is the first priority. Second, also abdominal muscles. For example, what I do is morning every day for at least 10 minutes, I put 10 kg of weight in my abdomen and try to raise my head to touch my knees. And also do Pavana Muktasana. So those basic training of abdominal and pelvic floor muscles, number one. Number two, they need to consume fiber. Make it a habit to you ask them to consume bananas. Some people are, particularly if they are diabetic, they are hesitant. Take it from me, nothing will go wrong. Banana gives them potassium also. So make it a habit of giving bananas at a fixed time, either in the morning or before going to bed, but not definitely with food. There should be at least 1 hour gap. Only when these two fail, look at the sleeping pattern. If they don't have enough sleep, they start thinking, and thinking causes muscular squeezing. So try to help them sleeplessness. Finally, mild laxatives can be used in these elderly people. But actually, when you practice, it is the reverse. The patient comes to you seeking immediate relief. So use some sort of laxative to start with. and then do the other three interventions slowly so that over a few weeks they will be able to be weaned off of these laxatives.
Thank you so much, sir, for answering and solving the doubt of Dr. Nitin Narula. I hope that doubts of all the participant has been clear. Sir, as I can see, there is no more question from the participant. With all your permission, shall we conclude this session for today?
Thank you. Thank you very much
Thank
for
you so
all.
much, sir, and
Thanks
it was a
again, all the
wonderful.
participants.
Welcome, sir, and hope to see you again with different topic in future, sir. Bye.
Thank you. Thank you. Bye.